Well, so I work in heart failure. I also work in imaging. And one of the things we've noticed is that heart failure is a condition where a lot of imaging tests are ordered, specifically MRI. And the guidelines are a little bit unclear as to when we should be doing these tests. And there's actually quite little evidence to support doing the tests. So we decided we needed to take a study to understand, better justify why the tests are being done and maybe under what circumstances the test should be done. So this was a multi-center randomized controlled trial. So we had 10 sites from Canada and 3 sites from Finland taking part in the study. And so we were basically randomizing patients with what we call non-ischemic heart failure to 2 strategies. One was echo with routine use of cardiac MRI versus echo with more selective use of MRI. And in the selective use group, we really limited MRI use to only a few specific conditions like ARVC, infiltrative cardiomyopathy, congenital heart disease, pericardial disease. So there's only a few specific things we wanted them to use it for. So we wanted to see, does one strategy or the other help the clinician downstream come up with a better diagnosis of the heart failure? So the results were negative. So what we found was that the imaging strategy of routine CMR did not improve the specific diagnosis heart failure rate in patients with heart failure as determined by the treating physician. So the treating physician, it didn't seem to impact what they thought was going on in terms of the heart failure etiology, which was a bit of a surprise, to be honest with you, because when we looked back and we looked at specifically what were the reports, the imaging reports saying, well, the actual imaging reports were coming up with more specific heart failure diagnoses, but for whatever reason that wasn't impacting downstream what the clinician was thinking. So that's quite interesting result for us. Well, for myself, I'd want to understand perhaps some of the reasons why it would appear that the information from the imaging wasn't making an impact on the clinician. So I don't know if that requires a better form of communication, maybe a face-to-face or verbal communication, or maybe there are some biases influencing how much weight the clinician puts on these reports. Maybe they actually put very little weight. Maybe for them there are other factors, other information that they receive that they value much more highly. So I think those are things we need to try to understand. Well, so like I said, we'd like to try to understand some of the biases that goes on between clinician decision making and imaging decision making. So that would be probably the next step for us. We are doing a bunch of secondary analyses as well to see are there any other information that you can get from imaging in these non-ischemic heart failure groups that helps predict outcome and ultimately improves the care for these patients.